Good morning, everyone. I'm Dr. VAIDEHI Rao. The topic of my presentation is outcomes of Descement stripping endothelial keratoplasty in iridocorneal endothelial syndrome. Iridocorneal endothelial syndrome is characterized by structural and proliferative abnormality of corneal endothelium leading to corneal decompensation and glaucoma. It includes a spectrum of three clinical variants such as essential iris atrophy, Fogan-Rees syndrome, and Chandler's syndrome. Corneal decompensation in eye syndrome was managed traditionally by penetrating keratoplasty, but recently posterior lamellar keratoplasty techniques like DSEC and DMAC have been tried. The objective of our study is to evaluate the outcomes of DSEC to manage corneal decompensation in eyes patients with concurrent or sequential surgical intervention for glaucoma. A retrospective study was done from January 2017 to December 2021, in which 11 patients with eye syndrome were included who had undergone manual DSEC for corneal decompensation with or without combined surgical procedure for glaucoma, either with trabeculectomy or RD implantation. All surgeries were performed by a single cornea and glaucoma specialist. Post-operatively, data was collected at 1 week, 1 month, 6 months, 1 year until last follow-up visit. The parameters assessed at each follow-up visit were best corrected visual acuity, intraocular pressure, and graft clarity. Moving on to the results, the mean age of the study group was 53.36 years, and out of the 11 patients, 6 were females and 5 were males. The indications of DSEC were primary corneal decompensation due to pathology of eye syndrome in 9 cases, and secondary corneal decompensation due to RD tube touching endothelium in 1 case, and due to iatrogenic decompensation after cataract surgery in other case. Next, the visual outcomes. The mean preoperative vision was 1.39 and the mean postoperative vision was 0.47. The postoperative vision was maintained in all the patients till last follow-up, except in one case where we had secondary graft failure, and the post-op visual acuity in one case was 6/60 due to pre-existing anterior stromal scarring. Here in this table, we compare the visual acuity of patients in whom glaucoma surgery was done before and after DSEC, and we compare their visual acuity pre-operatively, immediate post-operatively, and during last follow-up visit. In these, we have obtained a significant improvement in vision in immediate post-operative period. Similarly, we have compared IOP between the patients in whom glaucoma surgery was done before and after DSEC. But the IOP in these two groups remained the same. There was no significant difference in the IOP, and even in the pre-op and post-operative IOP, there was no significant difference. The mean duration of graft clarity was 2.18 months. The graft clarity was maintained in all patients till last follow-up, except in one case where regraft was needed. Along with DSEC, cataract extraction was done in 9 cases and RD tube trimming was done in 1 case. In all our cases, RD tube implantation was done in vitreous cavity except in this case. There were no intraoperative complications, and in postoperative complication, one case had graft failure which occurred 3 years later and for which regrafting was done and the graft was clear till last follow-up. One case needed rebubbling. All the cases had pre-existing glaucoma, which was managed medically and surgically. All the cases were on post-operatively AGM, except in 2 cases which did not require AGM. Then the surgical interventions included peripheral iridotomy for 2 cases, trabeculectomy for 2 cases, and RD implantation in 7 cases. Moving on to the discussion, surgical management in the form of DSEC is characteristically challenging because of the multiple anterior segment anomalies such as intraoperative IOP fluctuations, difficult lenticule insertion, and air tamponade. Here we have compared our study with similar studies conducted by AO et al. And Fajgenbaum et al. And in this we have obtained results in the form of visual outcomes and follow-up duration which are comparable. Technique of graft insertion. The technique of graft insertion and opposition is a rate-limiting step due to the anterior segment structure in eyes. In our study we had used TACO method in 5 cases and suture push-through in TACO in 7 cases and suture pull-through in 5 cases, whereas Fajgenbaum et al. Used TAN glide or Busen glide in all the cases, and MAO et al. Used suture push-through in all cases. In our study, graft clarity and survival rates in both methods are comparable. Though endothelial keratoplasty restores visual acuity, control of glaucoma is a significant factor which affects the long-term prognosis. In spite of high incidence of RD surgery in our study group, graft clarity was maintained in all the cases except in one case where regrafting was needed. Multiple anterior segment anomalies, need for additional surgery because of pre-existing glaucoma, and difficult graft insertion technique can all lead to more chances of graft rejection and need for lifelong immunosuppression. There was no significant difference in graft clarity and IOP control between patients in whom RD implantation or trabeculectomy was done before and after DSEC. An important contributory factor to this might be RD tube implantation in vitreous cavity. Though caution should be advised to avoid damage to the graft by GDD if the procedure is planned later. To conclude, though the literature documents scarce results of favorable long-term outcomes, our study shows optimistic outcomes of DSEC with graft survival with good IOP control in ICE cases with surgically managed glaucoma. These are my references. Thank you.
What was your longest follow-up?
Longest follow-up was for 60 months.
Okay. And they have fantastic results. Did you ever do, you didn't mention any synecholysis or anything in any procedure. Did you need any other additional procedures?
Pass release
during
was done during DSEC. Like first pass release was done and after the
There was no bleeding or anything like that?
No, not significant.
It was not then. Okay. And did you do multiple iridectomies at that time or you didn't do anything like that?
No, trabeculectomy was done in 2 cases prior only. After that, only RD surgery was done in some 5 cases later on.
And did they ever progressively form synechiae later on? ICE is known to progress,
Yes.
isn't it?
Yes.
None of them progressed?
No, synecholysis was not done.
No, I mean to say, after the procedure, after the DSEC, did synechiae continue to form? Did the ICE syndrome progress or anything like that?
Till now, they have not formed. In later on follow-up visits, like we have to see.
You're following up with gonioscopy and all that after
Yes.
that? Yeah.
So you have addressed 2 aspects of eyes very well, that is cornea and glaucoma. Another one what ma'am was mentioning was iris. So management of iris, pupilloplasty, breaking the synechia, that is again one extremely important procedure which determines the outcome. I think every corneal surgeon will agree these are one of the most difficult and challenging cases. And you have done it well. It was good study.
Thank you. Wonderful presentation.